Hi everyone from MedStream 360. My name is Dimitri Siqueira, and without further ado, I would like to show to you the case that we have for today. May I have the first slide, please? So this is a 75-year-old gentleman, non-frail, independent. As past medical history, he has hypertension, and he presented to our hospital with symptoms of heart failure, dyspnea class 2. On surgical risk assessment, the EURO score 2 is 1.1, and the STS score is also 1.1. So a low-risk patient for surgery. Lab tests are pretty unremarkable, except for the renal function is mildly reduced, 59, the GFR. His ECG, you can see here, he is on sinus rhythm with signs of pressure overload and a poor R-wave progression on the precordial leads. These are the echo findings. He has a preserved left ventricular function with EF estimated on 65%, mild mitral regurgitation. The mean gradient across the aortic valve is 66 millimeters per mercury, and the estimated aortic valve area is 0.6. This is a CT workup, and you can appreciate that this patient has a bicuspid, very calcified aortic valve. The annulus is eccentric, like we usually see on bicuspid valves. Diameters are 22 per 27. The area of the annulus is 470 square millimeters. He has no ascending aorta dilation. You can see here the measurements. The coronary height to the annulus are good, both on the left and the right. They are above 12 millimeters, so this patient has a low risk for coronary occlusion during the procedure. And here we can appreciate, we can categorize the type that bicuspid that this patient has. He has a bicuspid type 1 aortic valve with a raphe between the right and the left cusp. And in terms of sizing, you can appreciate on the left-hand side of the screen the intercommissural distance 4 millimeters above the annulus is 29 millimeters. And we also simulate two different sizes of valve using the three-dimensional software. And we simulated 24.5 millimeters and also 26 millimeters THV. And we decided here to implant 26 millimeters valve. This is the suggested coplanar view, LAO 22, caudal 7. You can appreciate here that the valve is horizontal with an aortic angle of 60. And here, Fausto, we perform a CT reconstruction of the axis, the femoral and iliacs, and you can see that this patient has diffuse disease and with small diameters. So I think that this is our major concern related to this case. So in summary, 75-year-old gentleman, non-frail, severe symptomatic aortic stenosis, low surgical risk score, and as anatomical challenges for this case, we can point it out bicuspid aortic valve, horizontal aorta, and a small diameters of the femorals. We selected this patient for TAVR.
What have you done so far?
So maybe Alberto could
Okay,
tell you.
Alberto, what have you done,
Hello,
please?
everyone. So first, we made the ultrasound guided puncture in the right femoral for the large bore access. The contralateral access in the left femoral, we puncture using ultrasound as well, and we use to protect with a 0.018 wire to lead with a complication if we have. So if you can see in the angiography.
And then we did our angel here. We have a coplanar view with the three cusps at the same plane.
Did
and
you get
can
some?
also appreciate how calcified this valve was.
So this is going to be a minimalist approach again.
Yep.
And have you got some echo images at this time?
Yes, we can show you
Yeah.
some images from.
We estimated the median gradient in 66. Today we got to see that it's 124 for 88. Yeah, the median is 88. It's an aortic valve extremely calcified. It's even hard to see the flux through the valve, through the native valve. And we also re-estimated the area. It's 0.7.
Do you usually use the echo images to help you?
To cross the valve, usually we don't use the echo image.
But after you cross the valve with the guide wire?
Of course. To place the stiff wire in the interior in the left ventricle, we usually use the
echo image.
The echo to help us to place the wire in the apex of the.
So Alberto just crossed the valve with a straight wire, and then we move to another projection to RAO.
It's a very, very important teaching because the complication can start right here. So if you use the echo just to see where you are with your guide wire, it's going to be really helpful.
So we're going to exchange the wires here, and we're going to put a long J wire.
Okay.
Just to put the pigtail into the left ventricle.
Again, as you have mentioned to you and during all cases that we have done, there are some rules that we need to follow. We cannot abbreviate the procedure. So now you have another wire. It's a soft wire, but it's a J wire. Just removing the unplatted catheter, following with the echo images. If you can show, Wendy, maybe can show us. You have the echo in the screen, please.
That we can see that the wire is over here, being at the top of the ventricle, and we can see with multiplane imaging.
So do you think the wire is okay, in a good position?
It's, okay. It's right in the top of the ventricle, in the apex.
Now we remove the unplatted catheter. Dimitri, please.
Yeah, so Fausto, obviously after crossing the aortic valve with the unplatted diagnostic catheter, it's possible to insert the pre-shaped wire.
Okay, I mean the stiff wire.
Yeah, the stiff wire. But our practice is not to skip steps.
Okay.
And we like to exchange the wires and put the pigtail and measure hemodynamics and
make everything safer.
Yeah.
Now we are going to do the measurements with the pigtail inside of the LV. And now, Dimitri, please.
So the gradient is about 110.
So the maximum gradient is 110. Just affirm that when the show does on the echo.
Yeah.
The mean gradient was 66 here?
88. Today was 88.
68?
88.
88 here, the mean gradient here. So the maximum?
124.
On echo also.
Great, thank you.
Because this patient has a small ventricle.
Now, Wendy is going to show us the wire position
Yeah,
in the
the
echo
wire.
that help us a lot.
It's a little low, still a little low.
Okay.
It's in the middle of the cavity.
Dimitri, are you satisfied
And,
with this position?
and it doesn't interfere with the mitral, right? Could you check, please?
In that position, it's kind of hard to
That's a
say.
very important point that Dimitri mentioned.
In that position, it's hard to say because all the subvalvular.
Because sometimes you can get a mitral regurgitation because of the wire.
Yes.
It
Okay,
does
great.
not seem to be interfering with the mitral
Okay,
valve.
good.
Thank you. So
Now,
Fausto, we are
Alberto
ready
is,
for
yes, for the
predilation.
pacemaker.
We're gonna use a LV wire for pacing,
Okay,
and we're gonna predilate with a 23, right?
23 balloon.
We usually perform a predilation when we are dealing with a bicuspid valve.
have you done a direct implantation?
Yes, we did, but this patient has a very calcified valve and with a high gradient, and it's also important to see the behavior of the balloon, and it's important here to confirm that the valve is already crimped.
And Dimitri, what is the current evidence supporting TAVR in bicuspid valve?
So, well, also we have no randomized data so far, but the knowledge, the evidence that we got from large registries have shown that the results are very encouraging, very good clinical results with a low rate of PVL. And there is some suggestion that the pacemaker rate are higher in bicuspid than tricuspid. Go ahead.
Oh,
Okay.
it's up.
Desliga o
Pacer
marca-passo.
off.
Yeah,
So this is very common in bicuspid.
because
right,
of the
Fausto?
horizontal.
Yeah, and because of the fact that it's a bicuspid valve, this kind of pop-up. We're gonna try again. 180. Sini.
Okay, great. Yes,
That's it.
good.
And pacemaker off.
Okay, predilation is okay. Now let's show the echo image, please. Okay.
Seems to be okay. It seems to be okay. It's not more than mild.
So Dimitri, the size for a bicuspid valve is different for a tricuspid.
Yes, we tend to be based on annular area. For this patient, we selected 26.
Because of the simulation you did.
Yeah.
Okay.
With the software.
So is there a difference between balloon expandable and self-expandable?
In terms of
The bicuspid?
I think that when we are using a self-expandable device, these devices are more forgiving. You can sometimes choose a bigger valve when you are dealing with a self-expandable valve. But with balloon expandable, we try to be precise in terms of sizing.
Okay. Alberto, you choose a MyValve balloon expandable valve. Could you please tell us which specific features of this kind of valve could be highlighted?
We have a bovine pericardium with an anti-calcification treatment called Antica. We have a PET puffing sternum to minimize the incidence of PVL. And what is important to highlight is the fact that the valve is crimped directly in the balloon. So we can retrieve the valve in case of inability to cross the annulus or another structure. For me, it's a good feature that we have in my valve. So the delivery system, we have one single step, that is the deflection wheel. We have to turn clockwise to give the deflection. Usually half of the deflection is enough to cross most of the anatomies.
How about the long-term follow-up of this? I mean, we have done for almost 2 years now. 2 years now.
Yeah, we already have the midterm follow-up with a good result. The patients are all of them less than class 2 of dyspnea, and the gradient and the aortic valve area is maintained during this period. It's also important to check the valve orientation. We have the external PET puffing here, directed in the distal part, and the open cells region in the proximal part. So it's
Can you zoom this, please? Thank you.
So it's aortic position. I think we can move on.
How hard is when you go to get across the introducer with the valve?
It is an expandable sheath, so you have to make some effort to expandle it, but it usually is not too hard to.
Yeah.
You can see it's not hard to push the valve.
Some injection here,
Yeah,
just
let's
to.
perform the first angel to confirm the position.
It's a good position, right?
Yeah, I think
What
so.
do you think so? So we are ready to implant the valve. So pacemaker on. Okay, 180.
Let's see.
Okay. Okay.
Go, go. 1, 2, 3, 4, 5.
Pacemaker.
Pacemaker off, please.
Okay.
Let's take a, okay, great, it's recovering. So do you think the echo images are okay, Wendy?
Yeah, it seems
So
to be
no
okay.
pericardial effusion,
No pericardial effusion, no
no
contractility
regurgitation.
alteration.
So this patient has a severe left ventricle hypertrophy. And when you open the valve, sometimes you takes time to get better and the heart can recover.
Yeah.
So can you show the echo images now, please?
Yeah,
Wendy, can you show
yeah. Here
the audience,
flux,
please?
right here, we can see the flux going through the valve, the prosthetic valve, and the gradient right here, 4, 2, with a peak max velocity of 1 meter per
Okay.
second. No pericardial effusion or ventricular dysfunction at all. Not increase of the intraventricular gradient.
I could see that. It's very
It's like
important you explain people
in
this.
terms
Yeah.
of a leaflet coaptation, it's like a volcano. And we tend to implant the valve a little bit higher, also to prevent conduction disturbance.
So I saw when Alberto was implant the valve, he asked for to do injection. Is that not common?
Yeah, Fausto, I can show you. The valve has a pattern, as you can see in the fluoro. We have a first dense band, one light band, and a second dense band. Usually, we use the second dense band to position where we have to reach. Usually, we are using the base of the pigtail. In this particular scenario, we use the base of the cusp to position in this place. During the inflation, if you perform an angel, you have a chance to replace the valve like millimeters or something to place in the best position we can reach.
Were you worried about the high implantation that you had to miss the valve or not? In this situation?
In the bicuspid scenario, we showed you that the calcification are in the top of the cusp. So usually the anchoring point is at that point, usually at 4 millimeters up in the annulus. So that were our goal to place the valve.
So Fausto, maybe Alberto can show to you the hemodynamics.
Okay, Alberto, please.
Yeah, as you can see there, we have no gradient, peak gradient, or only one gradient from the left ventricle to the aorta. I think it's a really good result, compatible with the echo. I think we can move on.
So what are your comments now, Alberto?
So we have no PVL, as we shown. We have no gradient. In my opinion, it's a really good result. I think we can move on and finish the procedure.
We have the echo images. What do you look for at this time? The procedure is just fine. We finish with low gradient, no aortic regurgitation by angel. What the echo can help us right now,
Well,
Wendy, please.
we must make a complete exam, not only see the prosthetic valve, we have also we have to see the mitral valve to see if that actually nothing happened when they liberated the valve, and we can see that the ventricular function is perfect the way it was before the procedure. There is no any segmental contractility alteration. There is no pericardial effusion, and we can also see the results in the hemodynamics the way we showed you. the minimum gradient. There is no exacerbation of the ventricular gradient, looking for some suicide ventricle or something like that.
I was going to the next room, but maybe you are finished now. I'm gonna just take a look. Can you just take a look when you finish this?
Yeah, yeah.
So, if you remember, we have a 5.2 in the femoral artery diameter. Is that correct, Dimitri?
Yes.
You know, Alberto?
Yeah.
So we are a little bit lower from the minimal.
Yeah, well, we're pushing a little bit the limits.
Yeah, you push it there. What can you do to avoid a vascular complication in a patient like this, Alberto?
When we have no calcifications, in my opinion, the access goes better than we have calcifications. In this particular scenario, we have no calcifications in the stenosis point, the 5.2. So we performed a contralateral protection. If we have an accident, we are able to go with a balloon.
So if you have a complication, what do you do with this?
We go with a balloon, like a 5 to 40 balloon. We inflate the balloon until we think or we have a cover stent or surgery.
So if you
like
go
that.
with a cover stent, you do through the contralateral.
Yeah, we go to the contralateral.
And you did a great procedure. So thank you.
Thanks for the opportunity.